Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can be profitable and successful for years to come. As many of you know, the NSCHBC is a proactive organization with over 300 members, including legacy members that share a wealth of knowledge and expertise with each other, whether it be in the legal field, accounting field, RCM field, value-based care, AI, and more. We have every kind of consultant that focuses on the healthcare industry that you could want. So today I would like to welcome to our episode of the NSCHBC Edge podcast, Tim Jodway. Tim is a manager at RubinBrown's Healthcare Consulting Services Group with experience spanning national healthcare consulting firms and senior leadership roles within provider finance departments, including multiple years as a CFO. Tim brings deep, practical, insightful information into the financial, operational, and regulatory challenges facing today's healthcare organization. His hands-on understanding of provider operations enables him to identify both immediate and emerging opportunities related to reimbursement, payment optimization, and compliance. Tim, welcome to the podcast.
No, thanks. It's great to be here, Terry.
Okay, so we have an interesting topic today. At least I kind of find it interesting. Hopefully our listeners will too. Well, let's just say the topic, we're going to make it interesting. How's that?
Sounds good.
So the topic is healthcare, I should say, HHS and CMS transparency. And I know people are like, oh, not that boring subject again. But as we keep seeing it in the news, we keep seeing our current HHS Secretary Kennedy and our CMS Director, Dr. Oz, they keep talking about the transparency, and I'm air quoting since we, are audio only. But it seems like they're going to use their statutory authority to control unnecessary, increases in volume of covered outpatient and inpatient services, and make sure that hospitals are letting patients know, how much things cost prior to getting things done. So, just putting it back to you, I just have first question, and before we get into, how patients will find all this information, one of the things I find because I'm on the RCM side of things, patients don't seem to care about the price if they've got insurance to cover it. They just want to know what their copay is or what their share of cost is. So if it's a MRI that's $5,000 versus $2,000, it doesn't seem to have big impact as long as they're like, I just want to pay my $50 copay. But somebody who's cash pay, that would be definitely something you'd want to know. What are your thoughts on that?
Well, I think I definitely agree with that. In 99.9% of the cases, I know from working on the hospital side that every patient is getting an explanation of benefits for their charges, and it'll list what the hospital charged, and ultimately the last number is what they're expected to pay. And I don't think we ever got complaints about what the charges were. It was always about what that ultimate last amount that their insurance company is going to require for them to pay.
Yeah, and it's interesting because a couple of years back, I had an episode where I needed to go to the ER. And, most people think you go to the ER, oh, that's going to be like $600-700. And it ended up being where I was there till 4 a.m., ended up coming home. And when I got my EOB, oh my gosh, $110,000 in charges. And I'm like, what did they do to me? How much were those Tylenol? I was just like, wow. And, my out of pocket was more than I wanted to pay, but I just thought, what the heck? And, this transparency sounds, fine and all, but do you know, how will patients get this information? Because I've looked at some hospital websites and, prior to this administration, because this isn't just this current administration. This has started, I think in Trump's first term, then spilled over into the last administration. And now it's also, really hitting home now. But there was a lot of facilities that seem to be fine with the $200 a day penalty for not giving that disclosure.
Yeah. So I think at the beginning, um, those penalties were in place, but they've really ratcheted up to a point where it's really not an option to forego all the disclosures. Um, and some of those disclosure requirements, there was a big change in the transparency rules for hospitals and for insurance companies that went into place April 1st. So it's continuing to be tweaked with um, incentives to make sure the providers put that information out there and the insurance companies, but also what's disclosed and how the calculations that go in those disclosures are made. So it's still an evolving field.
And they have to have it where it's easily translated to the patient, right? Because some patients are like, I don't know what I'm looking at.
Yeah, so there's a couple of different things that have to be disclosed for a hospital. Um, you've got a shoppable services list. So that's probably the document that is most likely to be able to be interpreted by a patient. It goes out there and lists the hospital charge for um, a
Mostly
list of,
diagnostics, right? Yeah.
yeah, there's a few hundred things on there. So diagnostics is a big piece of it, but there's things, additional things in there also. Um, and there is also a machine readable file that has to be put on the website of every hospital. This is not something that um, any patient or frankly anybody who doesn't work in the field would even want to download. But
Yeah.
there's a lot of third parties and the governments who are taking those files, combining them with other places, and doing comparisons. And I think a big part of the improvement over time, I think, will be that those third parties taking that data will be able to package it in a way that customers, patients will be able to use. Because even that shoppable service list um, doesn't really help you with your copay. There are hospitals that have a pricing tool on their website where you can put in your insurance and the procedure information, and it'll give you an estimate of what your copay is. But that's somewhat time consuming to do. So it's not, it's still not really where we want to get to. And frankly, that's only the hospital bill. If you're, if you take your example of the ER, um, you may have a separate bill from the emergency physicians if there were some diagnostics involved and a
Right.
CT. Okay, the radiology might have a bill for you, and maybe they do some lab tests and pathology has a bill. So to really know what your total cost for that episode of care, the hospital itself is only part, and it's the only one that it's currently has these mandated rules on what they have to disclose on their website.
So is this kind of going and coincide with the No Surprise Act? Just trying to make it a little bit, I don't like to call the word streamline, but at least be more upfront about, not post visit to the facility of what, could happen. Because I think a lot of people just get just such a shock after they've been in the hospital or after they've been in a facility stay and they're just like, whoa, what was that? Like I was.
Yeah, so one of the big problems that has been around for years that No Surprises Act was trying to address is that if you have a certain insurance, the hospital may accept that insurance, but that doesn't mean every physician who
Everybody else does, yeah.
treats patients in that hospital also participates. And you get into issues where your hospital stay was covered, but not the physician services that happened during the hospital stay. And
Sorry, not to
that was a
laugh, but
big
it's
part
just
of
so
it.
ridiculous.
Yep, yep. And so I would say that issue has reduced a lot. Um, and I think it was more specific to certain markets than others. I know in the experience that I've had that sometimes with a very obscure insurance, it's possible the hospital participated, but not a physician.
Yeah.
But it was pretty rare.
Well, I think one thing, not to get off topic of the transparency, but because I brought it up, but the one thing with the No Surprises Act that's really tough is that some of the doctors are like, I don't want to negotiate my rate. let's just find a way, especially anesthesiologists and radiologists, because they're on rotation and they're like, I just want to, or the hospitalists, they're just like, I just want to get paid for showing up and doing my job. And now they can't even get on some of the, PPOs and preferred provider lists. So that's been kind of an issue a little bit. One of the things you said before, and I wanted to just comment on that. So you said the transparency really focuses or is about hospitals. What about like ASCs or other facilities in that?
Yeah, so right now they're not subject to
They
the,
aren't. Okay.
so it's right now it's the insurance companies and hospitals.
Okay.
Um,
Okay. Now I have a question that's a little off topic. Can patients, so this is something that's happened kind of recently, and I just want to make sure, that any of our listeners that we have, providers, healthcare professionals. We also have some patients have looked us up, but also we have also the facilities and the physician practices. When a patient, it seems like, let's say a patient just wants to get an MRI and they say they want to get it at the outpatient hospital because that's what they trust versus an independent testing facility, an IDTF. Well, from what I've seen, you can't really get those unless you have a referral from a physician that has seen you saying you need one. And so just because a patient says, I want to go get an MRI, they don't let them have them. And so sometimes and it cross references to me to this transparency thing. it, it's just an interesting thing. I feel like HHS is trying to say, look what we're doing. This is so great, but I'm trying to figure out who is it great for? What is it really doing as far as lowering costs if first the patient can't get access to it unless they first see a physician to get something done? And can patients really shop around? I mean, it seems like a lot of things are based on what their coverage is.
yeah, so I mean, it is true that for MRIs and a lot of these, you're going to need um, a referral, a prescription essentially for that diagnostic test. But it is the case that you can take that to any participating provider and try to um, see what you can in terms of, can you see what the price is going to be before the test? Obviously, in an emergency situation, that's not going to really be something anybody can do. If you come to the hospital and they say they're going to take you for an MRI and you say, well, I'd like to see what the center across the street would charge. But for certain tests, yeah, your primary care doctor says you need a test and you can see what the outpatient center charges. If they disclose it, usually they will, because they know they're competing against the hospitals. The hospitals are required to show it on their shoppable services list. Um,
Well, and I
and
think
if
a
you're
lot of
paying
this,
cash,
well, a lot of people
that,
want to pay cash now because the ACA exchanges. I know my deductible is $10,000, so
yeah,
it wouldn't even kick in, And I think that's why some people, and I think this is one of the reasons this was brought up, is so people do have that option, even if they're covered for $10,000 deductible means, let's face it, you have major medical. That old
yes,
saying that we used to be able to have an option to just get major medical, but for anything that's just an outpatient thing, and it takes a lot to meet those deductibles. Now, another thing that was on the transparency list that I was reading through from the HHS secretary was that they're also trying to phase out the inpatient only list, which I'm controversial on that because I think it's important to expand the ambulatory surgery center covered lists and some outpatient situations to allow the physicians to have that greater flexibility to determine the most appropriate clinical setting for the patient. But I worry a little about safety, because I think sometimes people just look at money and not necessarily safety. I would hate to see a colon resection not be on a list in the inpatient hospital, or a CABG, a coronary artery bypass graft. So making those decisions, I hope that's a collaborative physician decision, and not, when they talk about transparency, not just to give everyone an option instead of having those safeguards still there. Did you see that on the transparency thing?
um, Yeah, so the inpatient only list was essentially a Medicare, it applies to Medicare
Right.
and um,
But some payers follow it as well, some commercial plans, right?
yeah. Yeah, and probably when the latest change to it, probably the biggest impact was some of the joint replacement for Medicare patients because a lot of the payers had already moved to paying that as an outpatient procedure, and Medicare was one of the few that was still allowing inpatient. Um, so, I mean, without the list, essentially you're relying on your physician to make a judgment call about other conditions that might mean that somebody needs to have the service inpatient versus outpatient, because um, even within the hospital, um, the surgery is the same. It's just a matter of whether they're staying overnight or 2 nights for the surgery versus being admitted and discharged through the outpatient surgery area.
So this
Uh,
would be based on what you were saying before, probably a good time for the patient to put in, well, they'd have to get the codes from the, billing department for the from the physician, but what they're going to end up having to pay.
yeah, that's definitely something that, especially if you're a Medicare patient, is to understand whether a surgery is going to be inpatient or outpatient, because the copays for Medicare, especially if you don't have a Part B secondary plan, um, the outpatient side is 20% of what Medicare pays. On the inpatient side, it's a fixed deductible for the admission, which I'm not sure I can remember off the top of my head what that number is, but it could be a significantly different number.
Yes, it's interesting because the transparency to me seemed to be kind of a generic statement that now we're going to know how much everything costs, but it seems like it's wrapped up in a lot of different things from statutory authority to controlling unnecessary increases in the volume of services, encouraging appropriate care delivery. It seems like there's a lot of that's going into that beyond just giving consumers meaningful price information.
Uh, yeah, I mean, I wouldn't necessarily say they're all directly transparency, but I think it's all a similar vein of trying to get better information to patients on all these areas and um, adjusting the regulations on a lot of um, other care to make sure that it's a competitive market and that cases that can be done in an outpatient or an ambulatory setting can be done that way.
Okay, and one of the things that I see, and I'll wrap it up on this one. It says the finalized changes. Who knows when it'll be finalized, but I know it's a working document. It says the finalized changes will require hospitals to post real consumer usable prices, not estimates, and provide data in standardized formats so patients can understand what their care will actually cost. Now, and they also say hospitals that fail to comply will face civil and monetary penalties. Is that something that you think they can actually enforce? I mean, who enforces that? HHS or DOJ or who does that?
So CMS does do audits. We've had clients who have gotten a letter from CMS that said their disclosures are not compliant. You have you need to file a corrective action plan to get it compliant. So it is going on. Um, the finalized rules that I think you're quoting, the word became effective April 1st. So before you would put out the payment rate from your insurance plan, basically from the contract. And the new changes on April 1st, you actually have to go through your payment data and calculate what your average payment received for that service is, as well as the 90th percentile, the 10th percentile. And you have to disclose the volume of those procedures. So is that average based on 100 procedures or under 10? So um, that change went into effect April 1st.
April Fool's Day. Perfect. I don't understand why they do that. I see so many things that go into effect on April 1st. I'm like, seriously? Do we really want to do that? Just funny to me. Well, that sounds just crazy. Just all that stuff is very interesting, and I think that definitely some heads up for our listeners. Now, I have a question for you, Tim. Now, is your client base, if they contact you, if you have a facility or hospital or something that you can get them in compliance and make sure that they do what they need to do?
Yes, that's one of the services we provide is work with hospitals on transparency disclosure and other consulting to be in compliance.
Oh, wonderful. Okay, great. Well, I would like to thank you for being our guest today on the podcast. And if you want to contact Tim directly, you can email him at tim.jodway, Jodway, at RubinBrown.com, RUBIN Brown.com. Thank you again for being here today.
Thank you.
To find a consultant for healthcare-related legal needs, you can also go to the NSCHBC website at nschbc.org and click on Find a Consultant and type in what services you need, and consultants with that background and what state will come up for you around the country. Also, as a reminder, the nschbc.org website offers monthly free webinars on a variety of topics, as well as a quarterly Medicare regulatory update. Please go to nschbc.org and click on the tab Upcoming Education. We have a variety of topics for 2026 that you don't want to miss. That's it for us today, everyone. Make it a great day, a great rest of your month, and thank you for listening to the award-winning NSCHBC Edge podcast. I'm your host, Terry Fletcher.
Thank you for listening to the NSCHBC Edge podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.